So now the next session is another interesting session. After hearing so much of COVID, now we go to some other topics now, and this will be something to do with nutrition. I think nutrition is picking up very fast, and it is equally important, rather more important nowadays. We are talking of immunity and so many other things. For that, we have a wonderful speaker, Dr. Anita Jatana, and begin the session. Can you unmute, Bhavna ji? Yes. We are not able to hear you. Bhavna ji needs to be unmuted.
You have to remove your headphone first. It will be a computer audio. So please remove the jack from your or a pen drive Bluetooth from your computer. Ma'am, we are not able to hear you. And we are not able to.
Can you remove your headphone? Yes. And remove the jack from the. Yes.
हाँ सॉरी सर वो काम करेंगे जो अनम्यूट रिक्वेस्ट सेंड करेंगे अपन आपने नहीं चेक किया
Okay, meanwhile, if there are some technical issues, Dr. Anita Jatana is a chief dietitian and nutritionist at Indraprastha Apollo Hospital, Delhi. She has a rich 35 years experience in the field of nutrition, and most importantly, she has won Apollo Innovative Award for Clinical Excellence for Research and has presented more than 50 scientific papers of different platforms. This is only one part of a bio sketch, which there's a very long process. Let us first go for the topic which we have really called up for today. So over to you, Dr. Anita ji, please.
Yeah, good afternoon, everybody. And thank you, Dr. Anand, for inviting me here. It's really nice. And I was listening to the lecture before that. So it was also very good initiative that you've done, Knowledge Forum. We really need it today and putting up with the latest information for all of us. So I'll just start. We've just heard that COVID and how even in geriatrics, they are the more people who suffer more. So it's not only COVID, it's for all the other medical problems. So is my screen there? Is it visible?
It is visible, but if you can make a slide show, it will be better.
Yeah.
Yeah.
That's okay? Yeah.
Yeah.
So I'm going to be speaking on nutrition in geriatrics. A couple of decades ago, I think we really didn't know too much of it. We just thought it's the same nutrition that they have to follow as they grow older. But we realized, no, it's a separate population and they need more special care than what we think they do. So I think we've all got people, maybe our fathers or our grandfathers there, and we realize how they go downhill. And of course, life expectancy has been increasing. And today we are 80. And as we grow older, we realize that, you know, the diseases catch you on. I know my father telling me at the age of 40, you'll become hypertensive, you'll need your specs because you can't read. So all those are signs of aging. And this is not the only thing. We are running you through that every organ is aging. And it's a lifetime approach. And India, of course, is going to be labeled as an aging nation. It is predicted it's a tsunami which is awaiting India. And we are going to have 300% increase in the population of elderly by 2030, which is not so far away, just a decade. And 60% of these will be dependent on subsequent generations. and almost 1/2 of India's disease burden will be borne by the elderly, which I think we all know that, you know, as you grow older, you become more medically prone to problems. So we want you to be healthy when you age, but when do we start looking after ourselves? We need to start looking after ourselves right from birth. In fact, there is a whole science that the first 1,000 days are important. The Barker's theory supports that a child born less than 2.5 years, 2.5 kg weight is more prone to medical problems as he grows older. We don't want a plump child. It's no longer in fashion. We don't want the zero size or an overweight in college. And of course, when you're pregnant, eat well, have a good baby, and grow old gracefully but healthy. So it has to be a life cycle approach. You can't say, I'm going to start worrying about my health when I'm 50. They are physiologic changes, which we can't help. Some of them will be there, but we can definitely slow down the process. So age-related muscle loss is there, but we can do a lot of exercise, eat well. We can slow the process. Bone weakening will be there, especially if we've not taken enough of calcium and vitamin D. The skin thins off. You can literally see your veins and arteries there. Cardiovascular disease, diabetes, respiratory infection, cancer. Of course, cancer happens at any age. It's got the young children also there, but obviously with aging, the prevalence increases. Cognitive changes happen, which is so difficult for them. We know the Alzheimer's and Parkinson's, and those are just progressive, and we don't know what's the way forward. So apart from aging, there are other also reasons why they become worse. There's malnutrition. You've seen that people who are well nourished obviously do better. Any acute illness, an injury, inflammation, hospitalization, sedentary lifestyle, chronic diseases all add on to the problem of muscle loss and the other problems which go with aging. Look at all those problems that happen, the chewing, the swallowing, the impaired upper extremity functions, mobility, cognitive impairment, depression, loneliness, poverty. After retirement, some are not so well off, and there's no support sometimes, and the diets are restrictive, they can't chew, all add on to the malnutrition at a very fast rate as you grow older. So we start with the teeth. This is the major problem which happens in them. You've seen, you know, the dentures are there, and once they're in hospital, they become loose because they've lost weight, and you find patients are not able to eat once they're in hospital. While you're home also, there is related tooth loss, so they start giving up foods which are more healthy. You're not eating your salads, you're not eating your fruits, you've left your nuts, you can't chew your chapati, so you choose softer and softer foods, giving up nutrition. Motor activity of tongue is lost. Saliva, the latest study in this area showed a significant decline, which is 50% of the saliva in the elderly, independent of medication. The medications add to the problems of giving you bad taste. Poor oral health status, and if you don't look after your teeth at that time, you have caries, you don't have money, and you end up with losing teeth and not being able to eat as you go along in age. The GI and the hepatic system, so it's very well documented. This is the ESPEN guidelines, which have come 2018. They've put geriatric as a separate chapter. They've put it up very well. What are the changes that happen in each organ in geriatrics? So geriatric individuals also subject to prolonged gastric emptying, so they're not hungry fast enough, and they tend to eat lesser quantities when so their food has to be more focused on nutrition. Gastric acid secretion decreases in secretion of acid and intrinsic factor, resulting in B12 malabsorption and pernicious anemia. Atrophic gastritis affects calcium bioavailability because of the limited ability to dissociate from food. Regarding pepsin, both basal and stimulated secretions decline after 70, and this decline in total capacity of liver to metabolize drugs can increase the incidence of drug reactions. So all very well categorized, as you see, in a tabular form. So that's the problem that we have here. The endocrine system, you know that as you grow older, you tend to become diabetic. Aging is clearly associated with the decline in the insulin action. Insulin resistance is there, resulting in higher PP concentrations. Decreased tissue responsiveness and reduction in hormone secretion from the peripheral glands, impaired glucose tolerance is over 50% of the individuals older than 80 years of age. And you've just heard COVID, that if you're on steroids, they add to the insult. In pancreas, you've seen the enzymes, the lipase, the chymotrypsin, MLI secretions due to both decrease in the secreted volume concentration, affecting the digestion of the fats and the starches. So all this also, and obviously the sugars. So all this are definitely involved. Nervous system, huge problems. Volume and weight of the brain declines at a rate of 5% per decade after age 40. So if you're living to 80 to 90 years, you know what's going to happen. And really, you see it yourself, things that you remember of your childhood, as you grow up, you just tend to forget. At that minute, you suddenly feel, oh, why can't I remember that name? And you really wonder, what is the problem? But there is science behind it. Once the brain is 70 years old, the rate of decline is thought to increase. There is greater loss of white matter than gray matter. There are cognitive changes with aging. Dopamine levels decline by around 10% per decade, starting in early childhood. Serotonin and brain-derived neurotrophic factors levels also decrease with age. Vascular distribution in the brain also change every decade of life. Oxidative damage and neural inflammation are the underlying biological mechanisms of neurodegenerative disorders like Alzheimer's and Parkinson's. Good nutrition, concentration of can decrease the oxidative damage, including elements such as manganese, copper, selenium, which are part of cofactors of antioxidant enzymes, as well as antioxidants, vitamin E and C. We are also doing a study, and there is a lot of research supporting the use of omega-3 for Alzheimer's. So let's see what the outcomes are, but there is literature which is supporting the use of omega-3 too in Alzheimer's. Cardiovascular, I think everybody will agree, there is a high blood pressure, similar heart rates and ejection fractions, lower left ventricular stroke volumes and cardiac outputs compared to younger population. These age-related changes in cardiovascular system primarily start with changes in the connective tissues. So we know, most of the time the atherosclerosis starts happening and more angiographies and bypasses are happening. So the lot of changes in the cardiac heart rate is increased, cardiomyocyte numbers is decreased, collagen cross-linking is increased, early diastolic filling is decreased, end diastolic filling is increased. So these are the changes in the cardiovascular system, which is going to end up maybe with problems and also total peripheral resistance, which will increase. Respiratory system, again, there are changes which include alteration of the mechanical properties of the respiratory system, the oxyhemoglobin saturation, and impaired response to hypoxia. Aging also affects the gas exchange properties. So they definitely, that's also what also makes them a little drowsy. There's also a decrease in the respiratory response to upper airway occlusion, and coughing and swallowing also diminish with time, making geriatric individuals more at risk for aspiration, which I think all of us see in our hospital setups. Renal systems, this is another problem. Also, aging causes both creatinine clearance and glomerular filtration rates to decline, resulting in increase in chronic renal impairment and end-stage renal failure. After fourth decade, there is a 10% decrease in renal blood flow, which is also there in each decade. So this is, the geriatric patients also have pharmacokinetic changes in the absorption, distribution, metabolism, excretion of the anesthetic drugs. So we've seen these patients, not being able, getting up too often. That's also because of the prostrate. And then the osmolarity also has to be monitored for these patients so that they do not go into dehydration. The thirst perception is low. So they sometimes just go into dehydration very fast. There's a frailty which is there. I think we've seen that very, very often in all the aging population. It's a very common sight. There's a decline in the muscle mass and strength, leading to development of the frailty syndrome. About 30% of the community dwelling persons older than 65 years, one or more falls every year. So this is the way it happens. And once they fall and they are on bed, then the pressure ulcers and all the other comorbidities also happen. So 5% of these falls result in fractures, and more than 90% of the hip fractures are attributable to falls. I've just had a patient also who had a spine fracture without a fall. That was because of his low calcium and vitamin D, did not ever have calcium in his food. So it has to be, again, a lifetime approach to make sure that these things can be avoided if we look after our diet. 15 to 25% require long-term nursing home care, and 10 to 20% die within each year. Again, musculoskeletal systems, sarcopenia is one huge problem, and the decline of bone mineral density, BMD, with increasing age can lead to osteopenia, and in extreme cases, osteoporosis. So this is what I was talking about, and elderlies are generally advised to strengthen their skeletal health by nutrient-dense diets, also diverse and rich in fruits and vegetables, making sure that we take an adequate amount of proteins and minerals, especially calcium, potassium, magnesium, and trace elements. This is where the Indian diets are really lacking. We take very, very low protein diet. Whenever we assess our patients, we find that the only protein they're probably taking is a 10-gram proteins in our diet. It's cereal-based, that's what we do. Aging and muscle, loss of muscle mass and strength, which is a natural part of aging. It's a loss of 8% for every 10 years. So you can see it all around us each time when we assess our patients. The percentage peak muscle mass is there. So healthy young, 28 days in activity, you only lose 0.4 kg of lean mass. Healthy elders, 10-day bed rest loses up to 2 kg of lean mass. And once they are hospitalized, it's 1 kg loss in 3 days. So this is where the nutritionists have to play a very important role, that you give them good nutrition, follow with active physiotherapy, which you can prevent, and which we've seen good results when we did a study on long-stay patients, neuro patients. When we gave them better nutrition, giving proteins up to 1.5, we found that we could maintain their body weights much better. Aging and muscle consequences, we all, I think, know that there's decreased immunity, there's increased risk of infection, decreased wound healing, increased muscle weakness, risk of infection, too weak to sit, pressure ulcers, pneumonia, lack of healing, and 40% increased risk of death, usually from pneumonia. So as the percentage of lean body mass increases, you are going to have a problem as we go along. Causes of muscle mass is biological aging. It's also malnutrition. This is the major problem, and this is where we can focus on. We can't change the biological clock, but we can arrest the other things and make sure that we can slow down the process. And let's assess, let's just not assume. Simple tests, BMI, cannot always tell you what is the muscle loss. So you can do a DEXA, or you can, and a very good, well-controlled nutritional screening. This is important for all OP and IP patients, and it is mandatory for our hospitals, where all the patients are screened the moment they enter. If we found that on screening they need assessment, then a complete assessment is done for these patients, and then a quick intervention. This goes a long way in improving patient outcomes. So screening and then they're reassessed every week when they're in hospital. On OPD settings, if they are already in the high risk, then they should be screened every 3 months. And if they're not, then once a year is good enough for them. A simple tool of mini nutritional assessment form is good enough. So just simple questions is all that you need to do. It's all available on net. Is your appetite low? Have you lost weight? Is one leading question which is so important. If he's losing weight without making an effort, it's time to sit up. Is he mobile? Has he got other psychological problems? Does he have any neuropsychological problems? What is his BMI? You rate him, and then you know anything that's 0 to 7 is malnutrition. If he's 12 to 14, he's good. But if he's on 0 to 7 scale, then he should be assessed. using the other form, which is on the right-hand side. How many full meals, selected consumptions. So then you assess them completely and do a scoring system again for them. Very simple, takes just a couple of minutes to be assessed by the nutritionist. So this is, as I said, but just explaining it to you, screening, yes, no, assessment, define goals, put the calorie goals on top of each sheet. Where is your calorie goal? But even if his calorie goal, according to the calculation, maybe 1500 or 2000 calories, please don't start there. You'll have to build him up slowly, just in risk of refeeding syndrome. Because when they're so malnourished, they develop diarrhea and refeeding syndrome. Handgrip is another good tool to use, very simple to do, very cheap to use, should be done for every admissions. So these are some studies which show that prognostic value of grip strength findings from a prospective urban-rural epidemiological study, which was published in 2015, which shows that hand grip was inversely associated with all-cause mortality, cardiovascular mortality, non-cardiovascular mortality, myocardial infarction, and stroke. So just doing a simple test like this will definitely help us to evaluate besides doing the nutritional screening and assessment. So this is another studies which shows that results suggest that increased relative hand grip strength may be associated with better profile of cardiovascular health biomarkers. So all these are supported with science and studies. Nutrition affects hand grip strength, a marker of muscle punctuality. Another study, supplementation for 8 weeks showed that they did much better. So doing bedside supplementation, if you find that the patient is not able to eat well, should be the way forward for these patients. And the absorptions are much, much lower in these patients. So do not just go by that, oh, I've given him an 80-gram protein, he's good to go. You'll have to really see how much he's eating also to evaluate. This is again results and conclusion of another study which says the hand grip strength increased significantly during the 8-week supplementation period. So they are all supported by science. So definitely make sure that we achieve the nutritional yardsticks for these patients once they are with us, and once they go home, that they continue on this and do much better, and no readmissions will be required. So all patients should be assessed on admission and assessed in the OP once they are there. So what is the optimal nutrition for these patients? Adequate nutrition, complete and balanced. They have a lot of food fats. They have a lot of allergies which they tend to have as they grow. Most of them have given up milk because they have a lactose intolerance. So you should come up with answers when they tell you that these are my problems that I'm facing. Complete nutrition with all the macro and micronutrients with essential fatty acids should be there in the diet, which is sometimes difficult to achieve because of all the problems that we have just discussed above. So a complete meal, guidelines, high quality proteins. As I said, we've done a study in our own hospital and we found that 90% of us were only taking 20 grams of proteins, much, much below than what we were supposed to take. Including fiber, prebiotic, electrolytes, and the macronutrients is the way forward for them. So this is what the tray should look like. And if you find they cannot chew their salads and all, we should grate it for them or blend it for them. They can't have their nuts. We can make a powder of them and make sure that they include all the food groups that they're supposed to be doing and remain a little active. These are the ESPEN guidelines, which clearly states that the energy requirements in older persons are 30 calories per kg body weight and not 20 and 25. Underweight people, it's even higher, and ill older persons is 27 to 30 kilocalories per kg. Now, as I said, we can't start at a very high level. If you find that they are malnourished, you'll have to go slow and slowly achieve your goals. Protein intake, 0.8 is what we should be saying in the adult, but for the older people, it's 1 to 1.2, which has been suggested by the several expert groups, 1.2 to 1.5 when they are sick in hospital, and 2 for severe illness, injury or malnutrition. So until more evidence is available, an intake of at least 1 But I would say 1.2, making sure it's a well-balanced, good quality protein. So we make sure most of the time our proteins are coming from cereals. It should be a combination of cereals and proteins from your dal, so that becomes a complete proteins. If they are allergic to milk, they can take curd base. And if still a problem, then paneer mostly they tolerate. Or lots of protein supplements are available which are lactose and gluten free, which is the way forward for them. Protein intake obviously decreases muscle loss more than the depletion. Again, a science and studies. So there, I think, is no doubt on the recommendations that they should be on a more than 1.2 gram protein intake. Protein intake, this study is there, but I actually don't support it. We Indians don't take proteins for breakfast. It's mostly cereal-based upma, poha, roti, toast. Lunch maybe a katori of dal. Dinner we don't take dal, or we don't take curds because of so many food fads. But the study says that the dinner is higher. As I said, our protein intake in India is very low, which is a major cause of malnutrition across all groups, not only geriatrics. We need our fats. There's a lot of hype about fats not being taken, not taking egg yolks. They are back in circulation. They are healthy fats. You can take one egg a day. And we definitely know that we need for the fat-soluble vitamins A, D, and K. So don't do fried foods, but they need the saturated fats also. The percentage of fats should be there, 30% of your total calories. Saturated fat should not be more than 7%, 10% from UFA and MUFA. And saturated fats, I think we all know, come from butter, ghee, creams. And the PUFA are plant-based, sunflower, corn, soya bean, and MUFA are from olive, canola, and peanut oils. So taking a combination, not by mixing, but combination of oils will ensure that you got all the oils in the right proportion. No to trans fats. We think only the fast foods are trans fats. All our Indian foods are also trans fats. All the bakery things, the rusks and the biscuits and all that, please go slow on that. This is definitely harmful. So this should be definitely on a low on the pyramid of the geriatric patients. Omega-3 is very important. I also said there is some.
Quickly, yeah. Madam, the time is.
Yeah, okay. I'll just quickly run through.
Yeah.
Fiber, 25 grams, considered adequate for normal laxation in adults. As I said, if they can't chew, blend it for them. All the micronutrients are there. If you cannot ensure a full meal, then giving supplements is the way forward for them. Fluids, we definitely need them. And as I said, they don't have this thing of thirst, but we should ensure that 1.6 for women and 2 liters for men is there. And they tend to avoid, especially for men, because they think they have to get up if they have a prostate problem. So they should be encouraged to take it during the day. I think we've talked a lot of this functional, difficult problems that we have, healthy aging nutrition, and the difficult things that go with them as they age. To summarize, we have all the organs which are definitely affected. So we need to definitely look after each one of them independently, see what is the medical problem that they are facing, plan their diet, ensure this continuation of nutritional strategy started in hospital. It has to be a multidisciplinary approach, should be communicated to the family together, implementation adapted, standard protocols for screening assessments, and the complete balanced nutrition can help in aging the optimal way. So aging is natural, yes, we cannot arrest it, but losing health is not. So if we look after ourselves, we take good nutrition throughout, I think we can move forward. Thank you.
Thank you very much. We are sorry we could have heard more, but because of lack of time,
yes.
There are certain interesting questions, I think, but maybe we can send you the questions and you can send the answers, because we are already short of time. Sorry, madam. Sorry for the delay.
Yeah. We'll mail you the answers. Surely. Thank you again, Dr. Anand, so much.
Thank you. Thank you very much.